My name is Rachelle Woods, and I am an HIV certified registered nurse with over 25 years experience in OBGYN, sexually transmitted infections, HIV, and infection prevention. I'm also the Colorado Department of Public Health and Environment Public Health Detailer. My role sits within the Office of STI, HIV, and Viral Hepatitis, and I'm tasked with keeping Colorado clinicians current in their knowledge regarding STI and HIV prevention, screening, including priority populations, testing, treatment, and linkage to care, and all things STI and HIV related. I'd like to start today by just briefly going over the goals of today's training. We're going to talk about some terminology that we'll be using in today's discussion. We're going to talk about factors that increase a person's risk for acquiring a sexually transmitted infection or an STI. We're going to talk about populations disproportionately affected by STIs and HIV. We're going to describe 4 common STIs, that being chlamydia, gonorrhea, syphilis, and HIV. And we're going to take a look at their modes of transmission. We are going to talk about the need for increased testing in ending congenital syphilis in Colorado. We're also going to talk about links between HIV and STIs. And we're going to talk about some risk reduction opportunities. And then right now, I'd like to draw your attention to the upper right-hand corner of our slide, our little condom guide there. You're going to find him on multiple slides throughout today's presentation. And anytime you see him throughout the presentation, just know that you're able to actually click on that and get additional resources once the slide deck has been sent to you following today's presentation. So I'm going to start by going over a few words. I know this is a very busy slide. It's not my intent to have you sit here and read this. More importantly, I put this in here so that when you receive copies of the slide, you're able to have this information. I just wanted to go over a couple of terms we're going to be using today and make sure that we're all on the same page. So when I am using the term woman or women today, I'm using that to describe persons who have a female sex assigned at birth. So that would be persons with a cervix. And this does include transgender men with cervix and gender diverse persons who have a cervix. In regard to the term transgender, we're going to use this as an umbrella term for people whose gender identity and/or expression is different from cultural expectations based on the sex they were assigned at birth. I also want to point out that being transgender does not necessarily imply any specific sexual orientation. However, so transgender people may identify as being straight, gay, lesbian, bisexual, etc. So just want to call that out that there's no specific orientation when that term is used. In regard to the terms man or men, we're going to be using those today to describe persons who have male sex assigned at birth or persons with a penis. And this includes transgender women with a penis and gender diverse persons who have a penis. In regard to the term men who have sex with men or MSM, this term comprises a diverse group in terms of behaviors, identity, and healthcare needs. In a clinical setting, the term MSN, or men who have sex with men, is often used in reference to sexual behavior alone, regardless to sexual orientation. Sexual behavior then refers to the behaviors we engage in when we have sex with another person or persons. An example, a person might identify as heterosexual or straight. However, that person can still be classified as MSM if they enjoy engaging in sexual behavior or having sex with other men. So today you'll hear me refer to this incredibly diverse community as men who have sex with men, or MSM, as well as gay, bisexual, or other men who have sex with men. Same group that I'm talking about within those various terms. And a key takeaway from our time together is that this group is disproportionately impacted by syphilis, HIV, and other sexually transmitted infections. And I also just briefly want to talk about the impact of STIs. Another important takeaway for today is that STIs have a profound impact on sexual and reproductive health worldwide, nationally, and right here in Colorado. STIs are an important global health priority because of the devastating impact on women and infants and because of their interrelationship with HIV/AIDS. Some STIs like herpes, gonorrhea, and syphilis can actually increase the risk of being infected with HIV, and we're going to explore that a bit further while we're together today. So let's go ahead and get started following the explanation of some terms we're going to see today. All right. So what is a sexually transmitted infection? STIs are infections transmitted from person to person through sexual contact. STIs can be caused by bacteria, viruses, or parasites. There's more than 30 different bacteria, virus, and parasites known to be transmitted through sexual contact, including vaginal, anal, and oral sex. Some STIs can also be transmitted from mother to child during pregnancy, childbirth, and breastfeeding. 8 pathogens are linked to the greatest incidence of STIs. Of these, 4 are currently curable, and that includes syphilis, gonorrhea, chlamydia, and trichomonas. The other 4 are incurable viral infections, and these include hepatitis B, herpes simplex virus, and that's herpes simplex virus types 1 and 2. Type 1 is more commonly associated with oral lesions, and type 2 associated with genital ulcers or lesions. Also, incurable viral infections include HIV and HPV. In addition, we do have emerging outbreaks of new infections that can be acquired by sexual contact, and this would include infections like Mpox and Shigella, and as well as reemergence of some neglected STIs, such as lymphogranuloma venereum. But today we're going to focus on 4 STIs, gonorrhea, chlamydia, and syphilis, which are caused by a bacterial infection, and HIV, which is caused by a virus. These STIs have considerable impacts on some populations more than others. So I'd like to start by taking a closer look at these populations, as well as at the factors that increase a person's risk of acquiring an STI or HIV. Okay, so let's take a look at some risk factors. And I want to start by pointing out that anyone having oral, anal, or vaginal sex is at risk for an STI. But we're going to talk right now about risk factors that actually increase that risk for both STIs and HIV. One of which is geography. This includes people who live in a high morbidity area or whose social circles or sexual networks are within a high morbidity area. The majority of areas, regions, or counties in Colorado are currently considered high morbidity areas. Sexual networks refer to a group of people who can be considered linked by sexual partners. A person may have only one sex partner, but if that partner is a member of a risky sexual network, then the person is at a higher risk for STIs than a similar individual from a lower risk network. Medical history and history of STIs is a high risk factor. This includes people with a recent history of syphilis or people having been diagnosed with another STI, such as gonorrhea or chlamydia or herpes, in the past 12 months, or persons living with HIV, and persons who have coexisting STIs. And this means a person who has 2 or more current STIs. An example might be somebody who has herpes and syphilis at the same time. Sexual history and sexual behaviors increase our risk factors, and this looks like things like inconsistent condom use, having a sex partner who currently has an STI, having new or multiple sex partners, having a sex partner who is having sex with other partners. Substance use prior to engaging in sexual activities is a high risk factor. Substance use disorder, including injection drug use, methamphetamine use, and alcohol, increase risk factors. Exchanging sex for money, drugs, or other commodities, including human trafficking victims, are at a higher risk. Folks with a history of incarceration, persons experiencing justice system involvement, including those under the supervision of correctional facilities or systems, jails, prisons, or probation. The prevalence of STIs and other communicable diseases among people who are incarcerated is also higher than it is in the general population. And believe it or not, stigma and secrecy are risk factors. Stigma is a negative attitude or belief about people with STIs, HIV, or substance use disorder, including both drugs and alcohol. It is the prejudice that comes with labeling an individual as part of a group that is believed to be socially unacceptable. Stigma and discrimination affect the emotional well-being and mental health of people that are living with HIV, STIs, and substance use disorder. And these people often internalize that stigma that they experience and begin to develop a negative self-image. They may fear they'll be discriminated against or judged negatively if their status is actually revealed. Internalized stigma or self-stigma happens when a person takes in the negative ideas and stereotypes about people living with HIV or STIs or an addiction and start to apply them to themselves. This internalized stigma can lead to feelings of shame, fear of disclosure, isolation, despair. And these feelings can also keep people from getting tested and treating for HIV, STIs, and substance use disorder. Additionally, the CDC has identified some priority populations in regard to sexually transmitted infections. So almost all epidemics impact some populations, communities, and geographical areas more than others, and STIs are definitely no exception. Again, the CDC has identified multiple groups that are at greater risk for acquiring STIs and HIV, and these folks include adolescents and young adults. While sexually transmitted infections affect individuals of all ages, STIs take a particularly heavy toll on our young people. In the United States, prevalence rates of certain STIs are highest among adolescents and young adults, and the CDC estimates that youth ages 15 to 24 account for almost half of the new sexually transmitted infections that occur in the United States. Persons who initiate sex early in adolescence are at higher risk for STIs, as are adolescents living in detention facilities, adolescents who are involved in commercial sex exploitation or survival sex, or are exchanging sex for drugs, money, food, or other commodities. Young males who have sex with males, transgender use and use with disabilities, substance misuse, or mental health disorders are also included in that higher risk category. Factors contributing to increased vulnerability to STIs during adolescence include having, again, multiple sex partners, sequential sex partnerships of limited duration, concurrent partnerships, failing to use barrier protection consistently or correctly, lower socioeconomic status, and facing multiple obstacles when trying to assess healthcare. The next group we're going to look at here is people, women and people with a uterus of reproductive age, so between the ages of 15 and 44. The rate of congenital syphilis cases has increased exponentially, both nationally and right here in Colorado in recent years. This increase mirrors the increase in syphilis and other STIs in women and people with the uterus of reproductive age. Everyone who is pregnant should be tested for syphilis, HIV, hepatitis B, and hepatitis C starting early in pregnancy, and repeat testing may be needed in some cases. Testing should be definitely conducted at that first prenatal visit, again at 28 weeks gestation, and those deemed at high risk, and that's the slide we just looked at with high risk factors, should also be tested at time of delivery. People of color and ethnic minorities, including non-Hispanic whites and people of color, are at an increased risk for STIs and HIV. Certain racial and ethnic groups have high rates of STIs when compared with rates for whites. In the United States, race and ethnicity is linked to other determinants of health status, like poverty, limited access to healthcare, fewer attempts to get medical treatment, and living in communities with high rates of STIs. Black and African Americans and Hispanic Latinos are also disproportionately affected by HIV when compared to other racial and ethnic groups. And then our MSM category of men who have sex with men. Gay, bisexual, and other men who have sex with men represent an incredibly diverse community. However, these men are disproportionately affected by syphilis, HIV, and other sexually transmitted diseases. In the United States, gay, bisexual, and other men who have sex with men are the population most affected by HIV and syphilis and are at increased risk for extragenital STIs. Transgender and gender diverse people are also a priority population. These transgender persons often experience high rates of stigma and socioeconomic and structural barriers to care that negatively affect their healthcare usage and increase susceptibility to HIV and STIs. And also, lack of medical provider knowledge and other barriers to care often result in transgender and gender non-binary persons avoiding or delaying preventive care services and incurring missed opportunities for HIV and STI prevention services. And transgender women who have sex with men are among the groups at the highest risk for HIV infection. Next, let's take a quick look at persons living with HIV. People who are living with HIV that are sexually active are also at a higher risk of acquiring an STI. Among persons with HIV and those at increased risk for acquiring HIV, the diagnosis and treatment of STIs is important for three main reasons. The first is because STIs are common among this group. The second is HIV can potentially impact the severity and response to treatment of STIs. And the third is that the development of STIs can impact the acquisition and transmission of HIV to others. Despite education and prevention efforts, national trends indicate a rising incidence of several STIs, especially among men with HIV who have sex with men. So clinicians providing care to these persons with HIV play a critical role in STI prevention through regular risk assessments and counseling, immunization for vaccine preventable STIs, routine screening, diagnosis and treatment of STIs, and partner services. I'm going to take a little deeper dive into a population focus here. Let's talk about folks with a history of incarceration, persons who are under the supervision of correctional facilities or systems. And again, that includes people who are in prison or jail or on probation or parole. According to the U.S. Bureau of Justice Statistics, there are over 5 million people estimated to be under the supervision of U.S. adult correctional systems. Multiple studies have demonstrated that persons entering adult correctional facilities and systems have a high prevalence of STIs, HIV, and viral hepatitis. And this is especially those aged equal or less to 35 years. Risk behaviors for acquiring STIs include condomless sex, having multiple partners, substance use disorder, engaging in commercial survival or coerced sex are, again, common among incarcerated populations. We should also call out that before their incarceration, many of these persons may have experienced limited access to medical care. And other social determinants of health, such as insufficient social and economic support or living in communities with high local STI prevalence, is also common within this group. So this is really where your help is needed in the fight against STIs and HIV. Growing evidence demonstrates the usefulness of expanded STI screening and treatment services in correctional care settings. And this includes short-term facilities such as jails, long-term institutions, prisons, juvenile detention centers, and through probation offices or officers. For example, in jurisdictions with comprehensive targeted jail screening, more chlamydia infections among females are detected and subsequently treated in the correctional setting than in any other single reporting source and might represent the majority of reported cases in certain jurisdictions. Screening in the jail setting has the potential to reach substantially more persons at risk than screening among the prison population alone. Both males and females aged equal to or less than 35 years in juvenile and adult detention facilities have been reported to have higher rates of chlamydia and gonorrhea than non-incarcerated persons within our community. Detection and treatment of early syphilis in correctional facilities might affect rates of transmission amongst adults and in turn have a positive effect on the prevention of congenital syphilis. So as you can see, addressing STIs in correctional settings is vital for addressing the overall STI impact among affected populations. Universal opt-out screening for STIs in correctional settings is also recommended by the CDC. So I have to be honest in disclosing that I personally am not fully aware of all the screening that happens in the various facilities within our state. I do know, however, that there is screening that happens and that in county jail screening, folks are usually released prior to the diagnosis. So an ask of our state department would be that you are all ensuring that there's good contact information, a good number, a location such as a home address, the parole officer's contact, et cetera, within a person's paperwork before letting them go. The Colorado Department of Public Health and Environment, or CDPHE, has resources available to assist in locating and treating folks who test positive for STIs, especially those who test positive during pregnancy and those individuals testing positive for HIV. So please reach out to me for additional information on this topic. I would be happy to connect you with the right folks at CDPHE who would be able to assist you in incorporating opt-out testing at your facility. And then also, I've included a link here for you to check out. NACHO has a Sexual Health Services in Jails webinar series. And NACHO is the National Association of County and City Health Officials. Their mission is to improve the health of communities by strengthening and advocating for local health departments, and that includes sexual health services in jails. So they've started the webinar series with the purpose to highlight and discuss how STIs are being addressed in jail settings across the country. And they're highlighting projects that specifically cover implementation, evaluations, lessons learned, best practices. So here I've provided you with the link for the second part of the Sexual Health Services in Jail series. And I chose this one because this episode highlights the efforts of our partners at the Pueblo Department of Public Health and Environment and the Pueblo County Judicial and Detention Centers. The collaboration focused on reducing congenital syphilis in Pueblo County. This program starts at intake into the county jail, where females of reproductive age are tested for syphilis, gonorrhea, chlamydia, and HIV, and pregnancy urine specimen is also conducted at that time. If the syphilis test is positive, they then perform a blood draw for confirmation, and then the individual receives their first dose of bicillin at that time. The CDPHE Disease Investigation Specialist, or DIS, is then notified, and the DIS and Pueblo County then work together to follow up with the client and potentially offer field-delivered therapy to the client. In August 2022, they added field delivery bicillin therapy for those pregnant women who tested positive for syphilis at time of intake. And since that time, they've had a 93% therapy completion rate through their program. So check out the webinar. The link is there. The highlighted Pueblo County section starts at 5225, as I've noted on this slide here. So check that out and see what good work they're doing down there in Pueblo. All right, let's take a look now at some concerning sexually transmitted infections that we're seeing increasing not only nationally, but right here in Colorado. So as I'd mentioned a few moments ago, we're going to focus on the four most concerning STIs being gonorrhea, chlamydia, and syphilis, again, caused by bacterial infection, and HIV, caused by a virus. On January 30th, 2024, the CDC released their Sexually Transmitted Infections Surveillance 2022 annual report. The annual report, which highlights that the syphilis epidemic continues to escalate, underscores that STIs must be a public health priority. Overall, in 2022, more than 2.5 million cases of syphilis, gonorrhea, and chlamydia were reported in the United States. The U.S. saw over 1.6 million cases of chlamydia in 2022 and just under 650,000 cases of gonorrhea. Within the STD epidemic, syphilis is one infection that stands alone. According to this report, syphilis cases, and I'm including all stages and congenital syphilis here, has increased 80% in the past 5 years. Cases of primary and secondary syphilis, which is the most infectious stages of the disease, increased 10% in 2022, which is a 68% increase since 2018. There were also more than 3,700 congenital syphilis cases reported in 2022, and this reflects an alarming 937% increase in the past decade. So let's start by taking a look at chlamydia. So what is chlamydia? Chlamydia is the most common notifiable, sexually transmitted infection in the United States. Chlamydia can cause infection in both men and women, and this infection, which is again caused by a bacteria, is transmitted primarily through sexual activity. This includes vaginal, anal, or oral sex, and less often through vertical transmission at birth. So let's talk about the symptoms of infections, or how do I know if I have chlamydia? Some refer to chlamydia as a silent infection. This is because most people with the infection have no symptoms or an abnormal physical exam finding. Most persons who acquire chlamydia remain asymptomatic or experience only mild symptoms, leading to a significant number of persons going undiagnosed and untreated for chlamydia. And because chlamydia can be asymptomatic, routine sexual health screening and STI testing is usually the most necessary thing to identify these infections. When symptomatic, though, infection with chlamydia can cause a wide range of clinical manifestations. In men, chlamydia can cause an array of genitourinary clinical manifestations, some serious. They can manifest as epididymitis, urethritis, proctitis, proctylitis. Epididymitis in males is caused by the inflammation of the coiled tube located beside each testicle. This is the most common complication of chlamydia infection in men, again, when symptomatic. Men with this complication typically will develop a fever, unilateral scrotal or testicular pain, swelling, and tenderness. This can also, in rare cases, lead to male infertility. Urethritis is the most common site of chlamydial infection in heterosexual men, so infection of their urethra. And although most men identified with urethral chlamydial infection have no symptoms, some will develop dysuria, which also means a difficulty in urinating. And they may also develop a urethral discharge, which is typically clear, mucoid, or mucopurulent. Chlamydia can also cause prostate gland infection, and we call that proctitis. Rarely, the chlamydia organism, can spread to the prostate gland, but again, when it does, it can cause an inflammation. Prostatitis can cause pain during or after sex, fever and chills, painful urination, lower back pain. Men may also have additional symptoms, including rectal pain, discharge, or bleeding. Most women with urogenital chlamydia infection initially have no symptoms or signs, but may later present with a range of manifestations and complications. And this includes an inflammation of the cervix, an inflammation within the urethra, and pelvic inflammatory disease. The cervix is the site of infection in about 70 to 80% of women with chlamydia infection, and most women with cervical chlamydial infection will be asymptomatic. However, when symptoms are present, they are often nonspecific and so vague, and this could include abdominal discomfort, perhaps vaginal spotting. They may include other findings as in regard to mucopurulent discharge, easily induced endocervical bleeding. Urethral infection with chlamydia in women may also, again, be asymptomatic. However, it could cause painful urination, burning with urination, and increased urinary frequency. And this actually can mimic acute cystitis or a bladder infection. So with that, oftentimes women can be misdiagnosed. Pelvic inflammatory disease is an infection of the uterus and the fallopian tubes that causes abdominal or pelvic pain and fever. And it can also cause permanent damage to a woman's reproductive system through the formation of scar tissue that blocks the fallopian tubes. And this can lead to a potentially fatal ectopic pregnancy or infertility issues, making it difficult or actually impossible to get pregnant later on. Let's also talk about manifestations that can appear in men or women in regard to chlamydia. So oral pharyngeal infection with chlamydia is possible. This is chlamydia that is spread to the throat during oral sex. And in both men and women, oral pharyngeal chlamydia infection is usually, again, asymptomatic. However, it can present as acute tonsillitis, acute pharyngitis, or an abnormal pharyngeal sensation syndrome within the throat. Chlamydia can also infect the rectum in both men and women. An infection with chlamydia in the rectal region is usually, again, asymptomatic. This infection can occur again in men or women, either or, who engage in receptive anal intercourse. And among women, rates of rectal infection are substantial, even among those who do not have receptive anal intercourse. In these women, the rectal infection presumably occurs via autoinoculation from infected vaginal secretions. Conjunctivitis, or infection of the eye with chlamydia, can occur as well in adults as a result of autoinoculation from the genital tract with secretions. And think of that as like hand-to-eye transmission. The most common presentation with this would be a unilateral eye discharge with clear to cloudy drainage. And then chlamydia can also infect infants and children. Although chlamydia infections are now seen infrequently among infants and children in the United States, they must still be considered in the scenario of an inadequate prenatal care scenario. Sexual abuse is also a major concern when chlamydia is detected in pre-adolescent males or females. And untreated chlamydia may also increase chances of getting or giving HIV. So, is chlamydia treatable? The answer here is yes. Laboratory tests can diagnose chlamydia. Your healthcare provider may ask you to provide a urine sample for testing, or they might use or ask you to obtain a cotton swab to get a sample. Nucleic acid amplification tests, or NATs, are the preferred diagnostic tests for chlamydia. And the optimal specimen types include, for women, vaginal or cervical swabs, or a first urine void of the day. And for men, a first void urine or a urethral swab. Extragenital testing can be conducted in regard to rectal and oral pharyngeal chlamydial infection amongst persons who engage in receptive anal or oral intercourse, and can be diagnosed by the same tests used on the urine specimens. Basically, we're testing at the anatomical exposure site in extragenital testing scenarios. The CDC STI treatment guidelines recommended regimes for chlamydial infections among adults and adolescents is doxycycline 100 milligrams orally 2 times a day for 7 days. If given medication to take for 7 days, it's important to wait until you finish all doses before having sex. It's important to take all the medication prescribed to cure the infection and to not share medicine for chlamydia with anyone. And reinfection is actually common. Repeat infection with chlamydia is actually really common. Folks who test positive should be rescreened and tested again about 3 months after treatment, even if sex partners receive treatment. All right. Next, let's take a look at gonorrhea. Gonorrhea is a sexually transmitted infection that's caused by Neisseria gonorrhea bacteria. You can get gonorrhea by having vaginal, anal, or oral sex with somebody who has gonorrhea. And a pregnant person with gonorrhea can give the infection to their baby during childbirth. In regard to gonorrhea and symptoms of infection, gonorrhea, like chlamydia, often has no symptoms, but it still can cause serious health problems. When symptomatic, Gonorrhea can potentially cause a wide range of clinical manifestations, including urogenital, pharyngeal, and rectal infections in both males and females, conjunctivitis or eye infections in adults and babies, and uncommonly disseminated gonorrhea infection, which is a gonorrhea infection throughout the body. If untreated in females, gonorrhea can cause pelvic inflammatory disease, tubal infertility, and ectopic pregnancy, as well as chronic pelvic pain. In men, urethritis is a common manifestation of gonorrhea, and the typical symptoms when present include a purulent or mucopurulent urethral discharge, often accompanied by difficulty urinating. Anorectal infection most often occurs in men who have sex with men through receptive anal intercourse. Gonorrhea is associated with increased susceptibility to HIV acquisition, particularly rectal gonorrhea in men who have sex with men. And most men with anal rectal gonorrhea infection are also asymptomatic, although proctitis can occur. Symptoms of proctitis would include then anal irritation, painful defecation, constipation, rectal bleeding, pruritus, and the feeling that you need to use the bathroom and have a bowel movement when in fact you actually do not. So that kind of describes like a pressure that you feel. Men with untreated gonococcal genital infection can also develop epididymitis, with the typical symptoms, again, of that unilateral testicular pain, swelling, and tenderness. Urethral infections in women are typically symptomatic. However, symptoms are often mild and can be mistaken for a bladder or vaginal infection. Symptoms in women usually include a burning sensation with urination, difficulty urinating, or feeling a urinary frequency. Most women with gonorrhea infection of the cervix are asymptomatic, but when symptoms of cervicitis occur, they may include vaginal discharge, intermenstrual bleeding, difficulty urinating, lower abdominal pain, and genital pain that can be experienced before, during, or after intercourse. Anorectal gonorrhea infection is uncommon in women, but it can occur via anal intercourse. And anorectal infection has been reported in women who do not acknowledge anal intercourse. And again, this is presumptively due to perineal contamination with infected cervical secretions that cause that anorectal infection. Pharyngeal infection with gonorrhea. Overall, most persons diagnosed with pharyngeal gonorrhea are again asymptomatic or have a very mild sore throat. Symptoms of pharyngeal gonococcal infection may include pharyngitis, tonsillitis, fever, cervical adenitis, or an exudate pharyngitis, which is rare. Gonorrhea can infect the eye. And again, this typically happens as a conjunctivitis and people who are, again, genital to hand to eye type of a infection, so autoinoculation. Clinical manifestations of disseminated gonococcal infection, while rare, can include a combination of skin lesions, arthralgias, arthritis, hepatitis, myocarditis, and meningitis. So, is gonorrhea treatable? Like chlamydia, laboratory tests, can diagnose gonorrhea. Also similar to chlamydia, the nucleic acid amplification tests are the preferred diagnostic tests. Same recommended specimens, so using urethral swab testing in men or women, as well as that first catch urine. For men and women who have receptive anal or oral intercourse, self-collected or provider-collected extragenital swabs of the rectum and pharynx can be used for testing. The recommended treatment regime for uncomplicated gonococcal infection of the cervix, urethra, or rectum is ceftriaxone 500 milligrams intramuscularly in a single dose. So that's a muscular shot that would be given. Any person who has a positive test for gonorrhea should be rescreened 3 months after treatment. For uncomplicated gonococcal infections of the pharynx, the same treatment regime would be given. However, alternate regimes are not an option, and a test of cure by either culture or nucleic acid testing, or NAT, should be performed 7 to 14 days after treatment, regardless of the treatment regime that was given. The rationale for that recommendation is that gonorrhea is more difficult to eradicate from the oral pharynx, or oral, the mouth, the throat, than in the urogenital sites. A high prevalence of gonococcal infection has been observed among men and women previously treated for gonorrhea. So what that means is that reinfection is, again, high and happens often, just like with chlamydia. Rescreening, reinfection, making sure we're completing our antibiotic regime are all ways to help avoid that reinfection. So the majority of these infections result from reinfection that's been caused by failure of sex partners to receive treatment, or the initiation of sexual activity with a new infected partner. So again, to avoid reinfection, patients and their sex partners should be instructed to refrain from sexual intercourse for at least 7 days after receiving treatment. And in addition, they should not resume sexual activity until all symptoms related to gonorrhea infection have resolved and their sex partners have received treatment as well. All right, let's take a look at syphilis. So like chlamydia and gonorrhea, syphilis is preventable and treatable. Syphilis is a systemic infection, and that means it affects the entire system or the body as a whole, and it's caused by the Treponema pallidum, a sphericate bacterium that is transmitted primarily through sexual activity or with vertical transmission during pregnancy. Cases of syphilis, including congenital syphilis, again, have risen substantially in recent years in the United States, as well as right here in Colorado. Syphilis typically follows a progression of stages: primary, secondary, latent, tertiary. And this can last for weeks, months, or even years. And in the absence of treatment, persons who acquire syphilis remain chronically infected and can develop an array of clinical manifestations. Let's take a look at what those manifestations look like. So again, syphilis typically follows a progression of stages. Individuals with HIV typically experience the same stages and physical manifestations of syphilis as persons without HIV, although the stages are more likely to overlap and the symptoms may be more severe. So in primary syphilis, usually occurs about 4 to 8 weeks after the exposure. The most common manifestation is a firm, oftentimes painless, genital or oral ulcer, and this is referred to as a chancre. Chancres generally appear at the original site of infection and usually last 3 to 6 weeks and heal regardless of treatment. And because they are oftentimes painless, they can easily go unnoticed. Persons with HIV who develop primary syphilis may have larger, more numerous chancres that take longer to heal during that primary stage. Secondary syphilis can occur following primary syphilis, but it also can develop in someone who does not have a clinically evident chancre. This typically occurs 2 to 12 weeks post-infection, and manifestations of this oftentimes includes a diffuse maculopapular rash, which is rough, red, reddish-brown spots on the trunk and extremities, which may involve the palms and the soles. This rash usually appears when those primary chancres are healing or several weeks after those have healed. And this rash is oftentimes so faint that it actually goes unnoticed. The latent stage, there are no visible signs or symptoms of syphilis during this stage. And asymptomatic persons who have a positive test for syphilis without a history of prior syphilis or previous treatment are considered to have latent syphilis. Distinguishing early latent syphilis from late latent syphilis is important since they require different treatment regimes. And I wanted to point out that your partners at CDPHE, can definitely help with questions of diagnosis when it comes to telling which stage somebody might be in when it comes to syphilis. Tertiary syphilis develops in up to 25% of untreated syphilis and occurs between 1 and 30 years after the initial infection, and multiple possible manifestations can occur, including death. And then neurosyphilis can occur at any stage of syphilis, and this would present as cognitive dysfunction, motor or sensory deficits, ophthalmic or auditory symptoms, nerve palsies, and signs and symptoms of stroke or meningitis. And then just another quick word of congenital syphilis. So the number of babies born with syphilis in the United States is increasing at an alarming rate. Congenital syphilis occurs when syphilis is transmitted from a pregnant woman with syphilis to the fetus. Transmission to the fetus in pregnancy can occur during any stage of syphilis, but the risk is much higher when primary or secondary syphilis, especially if the mother acquires syphilis in the third trimester of pregnancy. Increases in congenital syphilis are also reflective of the overall increase in syphilis among women of reproductive age that we spoke of earlier. Steady growth in primary and secondary syphilis among women of reproductive age fuels the congenital syphilis epidemic, and it definitely threatens the health of babies. Syphilis during pregnancy can lead to stillbirth, miscarriage, infant death, and maternal and infant morbidity, which are preventable through appropriate screening and treatment. I know I mentioned this earlier. However, there were more than 3,700 babies born with syphilis in the United States in 2022, over 10 times the number reported in 2012. And tragically, these 2022 infections resulted in 231 stillbirths and 51 infant deaths across our country. Nearly every state reported having at least one congenital syphilis case, and in 2022, Colorado had 31 cases of congenital syphilis. So a single injection of long-acting benzathine penicillin G, or bicillin, can cure the early stages of syphilis. This includes primary, secondary, or early latent syphilis. The CDC does recommend 3 doses of long-acting bicillin at weekly intervals for late latent syphilis or late syphilis of unknown duration. And treatment will cure the infection and prevent further damage, but it will not repair the damage already done. So again, selecting the right penicillin preparation is important to properly treat and cure syphilis. And again, I would encourage you to reach out to CDPHE, where our partners can help you in managing any diagnosis and treatments. Let's take a quick look at HIV. So last month when I visited you, we talked about HIV. So this is going to be repeat information for some folks. So HIV is a retrovirus that attacks the body's immune system. It disables the body's immune system until it's no longer capable of fighting infection off. And if HIV is not treated, it can lead to acquired immune deficiency syndrome, commonly known as AIDS. So this virus is transmitted through unprotected contact with blood or other body fluids infected with the virus, and this includes condomless sex. In the United States, HIV is mainly spread by having sex or sharing syringes or other injection equipment with somebody who's infected with HIV. Substance use can contribute to these risks indirectly because alcohol and other drugs can lower people's inhibitions and makes them less likely to use condoms. Anyone can contract HIV, and while injection drug users are at a greater risk because of practices related to their drug use, anyone who engages in unsafe sex could possibly be exposed to the HIV infection. So what does HIV look like? Once a person becomes immunocompromised, he or she can exhibit symptoms of weight loss, persistent low-grade fever, night sweats, and flu-like symptoms. The person is also more vulnerable to pneumonias, intestinal disorders, and fungal infections. When people with HIV don't get treatment, they typically progress through 3 stages. However, HIV treatment can slow or prevent progression of these disease stages. With advances in HIV treatment, progression to stage 3 or AIDS is less common today than in the early years of the virus. So let's take a quick look at what the stages look like. So stage 1 is acute HIV infection. Most people will have flu-like symptoms within 2 to 4 weeks after the infection, and some folks won't have symptoms at all. However, during this time, people have a large amount of HIV in their blood, and they're considered to be very contagious. The only way to know if you have HIV is to get tested. During this period where folks might be experiencing flu-like symptoms, testing is really the best option if there is a risk of exposure. Approximately 1 in 7 people don't know they have HIV because they haven't been tested. So this can mean both the patient inmate and the sheriff deputy healthcare worker are unaware of potential exposures or risks one another might present. Bottom line, if you have flu-like symptoms and you think you may have been exposed to HIV, get tested. Stage 2 is chronic infection. This stage is also called asymptomatic HIV infection or clinical latency. HIV is still active and continues to reproduce in the body. People may not have symptoms or get sick during this phase, but they still can transmit HIV. Antiretroviral therapy reduces the amount of HIV in the body or the viral load to a very low level, which keeps the immune system working and prevents illness. And this is called viral suppression. Stage 3 is acquired immunodeficiency syndrome or AIDS. This is the most severe stage of HIV infection. People with AIDS can have a high viral load and may easily transmit HIV to others. People with AIDS also have badly damaged immune systems, and they can get an increasing number of opportunistic infections or other serious illnesses. And without HIV treatment, people with AIDS typically survive about 3 years. So is HIV treatable? There's currently no effective cure for HIV. So once somebody gets HIV, they have it for life. However, with proper medical care, HIV can be controlled. People with HIV who get effective HIV treatment can live long, healthy lives and protect their partners from acquiring the virus. There is no vaccine against HIV, but there are definitely a lot of clinical trials going on to see if we can find an effective vaccine. All right, I want to talk to you about the link between HIV and STIs. So STIs can increase the risk of getting and transmitting HIV. The relationship between these are complex because it's both behavioral and biological. Behaviors that put someone at risk for one infection, such as not using condoms, having multiple partners or anonymous partners, often put them at risk for other infections. Also, because STIs and HIV tend to be linked, when someone gets an STI, it suggests they got it from someone who may be at risk for other STIs and or HIV. An ulcer or inflammation from an STI may allow infection with HIV that would have been otherwise stopped by intact skin. So if you think about the chancres of syphilis or the vesicles of herpes virus, that's an example of breaks in skin that allow HIV to more readily be transmitted. Kind of repeating myself, but certain STIs, against syphilis and herpes, that create those genital ulcers just cause these breaks in the lining of the genital tract, and it just really provides, it just really makes it easier to transmit and acquire HIV infection by offering an easy portal of entry. STIs also lead to cellular changes in the lining of the vagina, penis, rectum, and the mouth. STIs such as chlamydia or gonorrhea can create inflammation such as urethritis, which we mentioned earlier. And this causes an increased concentration of cells that the HIV virus can attach to, thus making it easier for HIV and other STIs to enter the body. People with HIV are also more likely to shed the virus when they have urethritis or genital ulcers. When a person with HIV gets another STI, such as gonorrhea or syphilis, it suggests that they were having sex without using condoms, and if so, they may have spread HIV to their partners. There is also an estimated 2 to 5-fold increased risk of acquiring HIV if exposed to HIV when syphilis or other STIs are present. And studies have also shown that syphilis and other STIs will increase the HIV viral load of somebody who already has HIV, thereby increasing the chance of transmission. HIV is more closely linked to gonorrhea than chlamydia, which is particularly common among young women. And herpes is also commonly associated with HIV. I also want to stress that many people who have an STI or HIV don't know they have it. The majority of STIs either don't have any symptoms or signs, or they may cause symptoms so mild that they're not noticeable. Therefore, people who have STIs don't even know they might be needing medical care. All right, I know we're getting close to time here, so I'm going to speed up. Prevention and correctional care, recognizing the risk. So we talked about risk factors earlier, and regardless of whether you're doing testing or not, there's some simple things that you can do as correctional care workers or officers to help let people know of their risk. Something that you can do to stop HIV epidemics in Colorado is to talk to those under your watch. Recognize the risks that the individuals that are under your care or your watch may have and discuss those risks with those individuals and recommend testing. Again, a great reminder of risk factors are geography, being in an area such as Colorado right now where we're seeing increases in STIs and HIV, being familiar with those sexual networks or groups of people considered to be linked by sexual partners, talking about medical history and history of STIs, talking about the importance of condom use, reducing partners, talking about substance use prior to engaging in sexual activities are all good ways. And then on a more personal note, reducing personal risk. So using condoms consistently each and every time. I've included a slide here, which again, you'll be receiving, of condom do's and don'ts, just to kind of help everybody understand how to properly use these. And then I've also included some links and graphics on the right way to use the various types of protective barriers for oral sex, the female condom and the male condom. All right, with that, I will conclude. I'm sorry that I did not leave a lot of time for questions. We had a lot of great stuff to cover. However, my contact information is here, and you are welcome to reach out to me at any time. We have just a couple moments left. If anybody has a question and wants to ask that, please feel free to do so.
Alrighty, I don't think anybody has any questions that I can see. Thank you so much. That was really informational, and I do appreciate all of you attending. Like I said, we will be posting this to YouTube, and we will also be sending out the survey once again. Oh, it looks like we do have a question in the chat. It says, what kind of testing would you recommend for short-term people in jail?
So I know that in Pueblo County, what they are doing right now are NAT testing, so the nucleic acid testing that I mentioned a little bit ago. And the preferred specimens with those can be a urine specimen, as well as a clinical or a clinician obtained, or a patient or self-collected swab. And that can be extragenital, so it can be oral swabs, rectal swabs. Women can do vaginal swabs. Men can do their own urethral swabs. And oftentimes, clinicians will provide some instructions for individuals on how to self-collect. It's an extremely easy thing to do. And actually, research has shown that self-collecting specimens is actually has more efficacy, let's put it this way, when people self-collect than clinician collected. And that's simply because people feel more comfortable in collecting their own specimens and doing these tests on themselves. So yeah, NAT testing with either swab or urine is usually that best option.
Wonderful, thank you. Does anybody else have any questions before we end this training? Wonderful. Okay, thank you again. And like I said, we will be sending this video out, or excuse me, the link to the survey and also posting this on YouTube. Thank you so much for your time, and I hope you guys have a wonderful afternoon. Thank you so much.
Thanks, everybody.